Hello and welcome. Let's start here is where we are at. Let's go. All right, so we took care of our pressure volume loops, basically chart there and looked at all the different events. And let's start here with cardiac output. So here when we talk cardiac output, I'd like you guys to know cardiac output is going to be the amount of blood that's pumped out by each ventricle in 1 minute. It's the amount of blood pumped out by each ventricle in 1 minute. It is the product, it is the product of heart rate times stroke volume. Cardiac output is the amount of blood that's going to be pumped out by each ventricle in 1 minute. It is the product of heart rate times stroke volume, as we can see here. Cardiac output equals heart rate times stroke volume. Cardiac output, as we can see, is roughly around 5 liters. Roughly around 5 liters. So, with that being said, the normal adult blood volume is about 5 liters as well. So we can see here the entire body's blood supply passes through each side of the heart once each minute. Heart rate, we know, heart rate is the number of beats per minute. And when we talk stroke volume is going to be the volume of blood. It's the volume of blood that's going to be pumped. It's a volume of blood that's going to be pumped out by one ventricle with each beat. By one ventricle with each beat. Now, stroke volume, I want you to know, is going to be correlated. Stroke volume is correlated with the force of ventricular contraction. That makes sense. Right? Stroke volume is correlated with the force of ventricular contraction. When we talk stroke volume, what is stroke volume? It's the volume of blood that's pumped out. So again, as I was talking about the other day in the other lab, where we're talking force of contraction, is that force of contraction a nice strong force of contraction, a nice strong beat? Or is this a faint beat? So you can see now how that is going to correlate. It's the volume of blood when we talk stroke volume that's pumped out by one ventricle with each beat. So now if that ventricle is not beating as strong as it could, you could see there stroke volume is going to be affected. Versus if you were to say, oh, it's beating even stronger than what we want there, then obviously we're going to have more blood being pumped out. So again, stroke volume is correlated with the force of ventricular contraction. When we talk cardiac output is going to vary directly. Cardiac output varies directly with stroke volume and heart rate. What does that mean? That means if either heart rate or stroke volume increase, this is also going to increase cardiac output. Opposite there, if either heart rate or stroke volume decrease, this is going to decrease cardiac output as well. Right? Because the amount of times it's going to beat and then the amount of blood it's going to pump out. Heart rate and stroke volume, two factors involved in measuring cardiac output. So here, I want you to know cardiac output is highly variable. It's highly variable and it increases. And it increases in response to special demands. Say you got to get to class on time or to work on time. You may not like wanting to get to class on time, but work you have no option. You got to be there on time. It's just to be ethical. You should do anything and everything ethically. So here, cardiac output is going to be highly variable, and it increases also in response to special demands. So here we can go through and we can see when we talk cardiac output at rest, this is how we came up with about 5 liters. Cardiac output at rest, okay, heart rate, about 75 beats a minute we have. About 75 average, 75 beats a minute. Stroke volume is about 70 milliliters. If you recall, if you go back to that pressure volume loop, we went up to 120 milliliters of volume inside of that ventricle, and we dropped all the way down to 50. There's your 70. If you don't believe me, there you go. Right? You're looking right here. You're at 120 and then you came down to 50. So that's a stroke volume. And you can see it's abbreviated there as well. Because we talked end diastolic volume and we talked end systolic volume. Now, again, I said if either increases, okay, cardiac output is going to increase. If either decreases, meaning heart rate and stroke volume, that'll cause it to come down as well. So maximal cardiac output is 4 to 5 times resting cardiac output in non-athletic people. Now, maximal cardiac output may reach 35 liters a minute in trained athletes. They're constantly pumping that blood all the way through. Sedentary lifestyle, right, they describe as not being one of the healthiest things there. So we've got to get up, got to move. All right. Now, when we talk cardiac reserves are going to be basically the difference between the resting and maximal cardiac output. So that's your reserve. It's the volume that's going to remain in there. Next in here, we can look at this chart here. Let's look at this chart here. It goes through the factors that are involved in determining cardiac output. So here we can see when we talk cardiac output, a whole bunch of different factors that are going to determine it. Okay. Now here we could see all of these various factors that I'm telling you that are going to determine it are going to come down to either altering one or both of those factors, heart rate and stroke volume that we're going to see. So here we could see now, when we go through and we talk exercise, what is exercise going to do? Exercise is going to increase sympathetic activity. It increases skeletal muscle activity, also increases your respiratory pumps, right? What are these pumps going to do? What do these muscles do? What is this increasing sympathetic activity all doing? It's all helping to increase venous return, right? Respiratory pumps, what are we talking about? We're talking about how skeletal muscle is going to be involved in helping to get blood moved forward in your venous system, right? Because you should recall from anatomy, when you talk about venous blood circulation, it's totally different from that of arterial. Next, then, we can see exercise will increase venous return, which will increase your end diastolic volume, which then is going to increase your stroke volume, which we said is going to increase your cardiac output. Now, here's the same thing with decreasing heart rate. Now, if we were to decrease heart rate, okay, by decreasing heart rate, this is going to allow the ventricles to fill with higher quantities of blood. So here we say then we have increased venous return, more blood coming back, because the heart's going to be decreased heart rate, okay, is going to cause then increase in venous return. It'll be in diastole longer, right? That's the phase of filling. And what is increased venous return? If you have more venous return coming in, this is going to cause an increase in end diastolic volume. So if this venous return is higher, that's going to cause that end diastolic volume to go even higher as well. Increasing, obviously, stroke volume and increasing cardiac output. Now, we also have some blood-borne chemicals here, epinephrine, thyroxine, or even excess levels of calcium. What do all of these factors here do? All of these factors here, what they do is they increase contractility. They will increase contractility. So now if you increase contractility, this is going to decrease end systolic volume. Right? Because if we come here, end systolic volume is the volume of blood that's going to be left after contraction. But here, we're increasing that contractility. So we're going to be decreasing end systolic volume. So when we decrease end systolic volume, that means we pump more blood out. We had an increased stroke volume, which increases cardiac output. When we talk exercise, fright or anxiety, we saw that reaction basically occurring here, but now look at here. Not only is it going to affect venous return, exercise, fright or anxiety, but here you can see they're going to affect heart rate. So when we are scared or we have anxiety going on or we're exercising, we have an increase in sympathetic activity, which is going to cause an increase in heart rate, which increases cardiac output. This increase in sympathetic activity, we saw it also is going to increase contractility, you can see running off this way. Now, if we increase contractility, we're going to increase stroke volume. And that increases cardiac output there as well. So you could see here very well the various factors that are all involved with helping to increase cardiac output via our two main factors, stroke volume and heart rate. So when we talk stroke volume then, here we could see stroke volume. Now we could see when we go, all right, so here talking about stroke volume, right? So one of the two factors that are going to affect cardiac output. Right, we're going to get into heart rate also. Heart rate, I mean, it's not much even there. Right, heart rate is either going to go up or it's going to go down. That's going to be thanks to, we've seen sympathetic or parasympathetic activation. Now, when we talk stroke volume, then the other factor. Now, stroke volume, I want you guys to know, first of all, the definition of stroke volume. Stroke volume is going to be the difference between end diastolic volume and end systolic volume. The difference between EDV and ESV. Or we could say there, end diastolic volume minus end systolic volume is equal to stroke volume, right? That's what we calculated before. We saw there with the volume of 70 milliliters of blood. So here when we went through, we talked stroke volume, end diastolic volume, which we saw was about 120 milliliters of blood. And then here we had end systolic volume, which we saw was going to be then 70 milliliters of blood. Now here when we go through and we talk stroke volume and heart rate, here we could see stroke volume. So we consider stroke volume to be the quantity of blood pumped by each beat. The quantity of blood that's going to be pumped by each beat. So stroke volume is equal to end diastolic volume minus end systolic volume. We saw end diastolic volume to be 120 milliliters of volume of blood inside the ventricles. And then end systolic volume we saw to be 50 milliliters of blood within the ventricle. So minus the two, you've got 70 milliliters of blood. Now, when we go through, so again, it equals to 70 milliliters of blood per beat. Per beat. It's the volume of blood pumped by each beat. By each beat. Now, end diastolic volume, I want to remind you, it's the amount, it's the volume of blood that collects in a ventricle during diastole. So we talk end diastolic volume, it's going to be the amount of blood that collects in a ventricle during diastole. End systolic volume then, end systolic volume, ESV, is the volume of blood remaining in a ventricle after it has contracted. The volume of blood remaining in the ventricle after it has contracted. So again, EDV affected by length of ventricular diastole, right? If ventricular diastole lasts longer, we're going to have then higher end diastolic volume. More blood is going to make its way in. So it's affected by length of ventricular diastole and venous pressure. And systolic volume is affected by arterial blood pressure and the force of ventricular contraction. There are many factors that affect stroke volume by altering end diastolic volume or end systolic volume. The three most important factors The three most important factors are going to be, as we can see here, preload, which is going to affect end diastolic volume, which will affect end diastolic volume. The second factor, contractility. We're talking here whether the beat is strong or it's weak. And then third factor, third factor, afterload. Third factor is going to be afterload. When we talk afterload, we'll talk afterload in a few seconds. And I want you to know, afterload and contractility are going to really affect end systolic volume. We'll see, ESV. So EDV is going to be more affected by preload. Now, preload, let's talk first then. So let's switch slides. So here you could see this equation where cardiac output is equal to heart rate times stroke volume. So if you have a certain heart rate, right, you're given one, you'll multiply that by stroke volume, and then you come up with your answer there. I'm pretty sure I won't do something like that. It's too simple, it's too easy. You should be able to figure that out. I'll probably ask that in words, through to see if you know cardiac output equals to heart rate times stroke volume, or something of that nature. But I'm 100% sure I don't have a calculation for you on that. I have enough other calculations we're going to get to, and we're going to see. That's going to get into filtration across the basically blood vessel, and there you're going to have one equation that you have to know, and you have to work out and be able to do. And you'll probably have two questions in regards to that. So I'm telling you all that now. There's no excuses. You have enough time to prepare and know what you need there. And there it'll probably be a two-part question for each one. So I've told you guys this before as well. So that ends up becoming like 2, 4, 6, 8 points there. So that is where I'm going to save all of my equation stuff that you need to know. Because I'm telling you, these are going to become like second nature for you. You're going to know these like nothing. Okay, it's the other one that's going to give everybody a problem, but that's the one that you've got to know and be able to understand. At least be able to understand the idea, because it's going to get into the explaining the concept of edema as well. That's the main reason why we mentioned that there. Edema. So here now, let's talk preload. Okay, so stroke volume, same thing you see here. This stroke volume is equal to EDV minus ESV. That was mental math. We did that real quick. So don't worry, you're not going to see an equation or anything in regards to that. So let's talk preload then. Preload, we're going to be looking at the degree of stretch here now. So we're looking at the degree of stretch of heart muscle. That's what preload is. Now, preload is going to be the degree to which cardiac muscle cells are stretched. When we talk preload is going to be the degree to which cardiac muscle cells are stretched just before they contract. So you can think it's the load before the load, the preload. So it's the degree to which cardiac muscle cells are stretched just before they contract. It controls stroke volume. In a normal heart, the higher the preload, the higher the stroke volume is going to be. This relationship between preload and stroke volume, this relationship is called the Frank-Starling law of the heart. Frank-Starling law of the heart, it states if you put the right amount of stretch on a muscle, you can have optimal stretch of those fibers. All right, hence exercise. What do we do in exercise? Stretching. Okay, doing what we got to do there. Same thing with athletes. It's very important. Okay, so again, you can see Frank-Starling law talking about basically the degree of stretch of cardiac muscle cells before they contract. So this relationship, okay, is called Frank-Starling law of the heart. The stretching is very important. We see it here with that cardiac muscle, and then obviously with skeletal muscle, right? We have it there, and we see the importance of that. like I said, in exercise. It's very important. Athletes have special trainers and other individuals that come in and they're paid big bucks just to come in and stretch these people out and get them ready so that way they don't have any injuries and their muscles can perform optimally, right? Last thing you'd want to see is Messi or somebody, another athlete, LeBron James, or somebody there not performing. You paid to go watch them, or you paid a show for PPV show, or to watch them, and they're not doing what they're supposed to be doing, or they're not performing like they should. It's kind of a little bit of a letdown. So this is all a part of that business there. That stretching, having their health and their muscles and everything else taken care of is very important for these athletes. So here now we can see it in relation to the heart. So now here as we continue, here, we're able to see basically that stretching cardiac cells can produce a dramatic increase in contractile force. Stretching cardiac cells can produce dramatic increases in contractile force. Now the most important factor that's stretching cardiac muscle is going to be venous return. It's going to be venous return. This is the amount of blood returning to the heart and distending its ventricles. The amount of blood returning to the heart and distending its ventricles. So here you can see cardiac muscle exhibits a length-tension relationship, and at rest, cardiac cells are shorter than optimal length. So anything that increases the volume or speed of venous return, such as if you have a slow heart rate, okay, anything that increases the volume or speed of venous return, such as if you have a slow heart rate or exercise, they will cause increases to the end diastolic volume and consequently stroke volume. Along with that, we'll see also increase will be contraction force and cardiac output. Contraction force and cardiac output. A slow heartbeat is going to allow more time for ventricular filling. So let's go back here. You could see that anything that increases the volume or speed of venous return, such as a slow heart rate, okay, or exercise, they will cause increases to EDV and diastolic volume, and consequently to stroke volume, cardiac output, we said, and the force of contraction. Now, a slow heartbeat, I was telling you, is going to allow for more time. It allows more time for ventricular filling. Exercise, it speeds up venous return because both increased sympathetic nervous system activity and we said the squeezing action of skeletal muscles on the veins compresses the veins, decreasing the amount of blood that they contain, again, then helping to return more blood back to the heart. And then increased venous return distends or stretches the ventricles and increases contraction force. So we talk contractility then. Contractility is also going to affect stroke volume. Contractility also affects stroke volume. EDV, end diastolic volume, is going to be the major intrinsic factor that influences stroke volume. There are also extrinsic factors. And these factors increase heart muscle contractility, and also enhance stroke volume. Contractility is the contractile strength achieved at a given muscle length. You would really be able to understand contractility if we're still doing our labs when we do our frog dissection. I can't tell you how beautiful that lab is. I mean, in relation to, or in the sense of educating your mind, or applying what you were educated there, and being able to understand that contractility. It's an important factor there. So contractility is the contractile strength achieved at a given muscle length. Now, contractility. Okay, this force of contraction, contractility arises when more calcium enters the cell or is released from the sarcoplasmic reticulum. I mean, that's going to make sense, right? Because then what's it going to do? It's going to enhance more cross bridges. Enhanced contractility, it means more blood is ejected from the heart. Increased sympathetic stimulation increases contractility. Sympathetic fibers, they serve in the intrinsic system. So sympathetic fibers serve intrinsic system and the entire heart. We saw that yesterday in last class. I don't know if you saw it yesterday, but in the last video. I have to remember we're virtual. So again, increased sympathetic stimulation increases contractility. Sympathetic fibers, they serve the intrinsic cardiac conduction system we saw, and basically the entire heart. Norepinephrine and epinephrine increase calcium entry into the cell via cyclic AMP second messenger systems, which then promote cross-bridge binding, and they increase ventricular contractility. And they'll increase ventricular contractility. So here, coming back, you can see again various factors. Epinephrine, norepinephrine, and thyroxine we said there, as well we can add to the list, are going to all increase calcium entry into the cell via the cyclic AMP second messenger systems, which promote then cross-bridge binding and increasing ventricular contractility. Right? Stroke volume going up, cardiac output going up. There's other substances that I would like you to know. There's other substances that increase contractility. And these other substances that increase contractility are going to be called positive inotropic agents. Positive inotropic agents. Epinephrine, thyroxine, glucagon, digitalis, and also high levels of calcium, high extracellular calcium, you can see there as well, all positive inotropic agents. And they're going to increase, we said, contractility. Increase contractility. Now, when we talk then, negative inotropic agents are going to impair or decrease contractility. They will impair or decrease contractility. And they're going to include factors such as acidosis, where you have excessive hydrogen ions, or if there's rising extracellular potassium, increased extracellular potassium, and also calcium channel blockers. Calcium channel blockers. Calcium channel blockers are going to be a class of medications in relation to the heart that you're going to have to know about. So you do yourself a favor, you get that down now, and by the time you get to farm, is a class I suggest if you've got time on your hands to take. It's in our allied health department, and it's a 3-credit class, and I hear it should be like a 5-credit class. It's a tough class, pharmacology in itself, and it helps to prepare you a bit for what you have to look forward to when you get into the nursing program. So it's a good way to expose yourself to this material. One way. So calcium channel blockers is 100% guaranteed. Star it, underline it, highlight it. This is something you have to know for the rest of your life. A class of drugs you have to know for the rest of your life, especially if you're going to be in primary care. For sure. So let's move then, and we've got there, then we can see now how basically all of this is going to occur. Now, here when we look at this basically picture here, in this picture, we can see now norepinephrine coming in, and when norepinephrine comes in, it binds to, you can see beta 1 adrenergic receptors. It's important you remember you have one heart, and which receptors? Beta 1 receptors, because you also have beta receptors in your lungs. Those receptors there are the beta 2 receptors. Beta 2 receptors. And how do you remember that? There's 2 lungs. Let's get to the hard stuff. Okay? So that's one way to remember beta 1, beta 2, because when you're going to have patients, sometimes you're going to be giving patients just beta non-specific drugs, and that's going to be medications you got to give to people who don't have any, other conditions such as asthma, for a heart condition you're trying to treat, because then you're going to exacerbate that asthma. So there it's going to get very specific in, are you going to give beta 1 specific medications? Or if you have somebody like when we give epinephrine, or if we take these asthmatic medications, what happens with them? Heart rate goes up as well. Okay, so they increase heart rate. Why? Because they have an effect on those beta receptors there as well. They're not as specific to just the beta 2 receptors. So, very important. You can't, give breathing treatments, or, these medications that get that heart rate going one right after the other. You have to have a little bit of a gap in between them, because then this heart rate increased heart rate could become a problem in some patients. Now, let's say you have an asthmatic patient who's got heart problem there as well. You've got to now make sure you know exactly how you're treating this patient. So you could see we can go that way or we can go this way. Either condition now, we've got to be able to look at in relation to the pathologies to both of those organs there. So here we can see norepinephrine comes in and binds to beta 1 adrenergic receptors, which then are going to activate GTP. GTP then is going to come in, activate adenylate cyclase. Adenylate cyclase converts ATP to cyclic AMP, and then cyclic AMP is the second messenger here, and cyclic AMP comes in, it's got basically the ability to do, you can see here, various jobs. Number one, it could come in and it can phosphorylate these plasma membrane calcium channels, increasing calcium entry, increasing then, you can see contractility, as we talked there, increasing, we said being a positive inotropic factor there, right, calcium. So when we talked being positive inotropic factor there, we said then that these positive inotropic factors are going to increase contractility. Also here you can see what it can do is it can phosphorylate sarcoplasmic reticulum calcium channels, increasing intracellular calcium release. And then also phosphorylates sarcoplasmic reticulum calcium pumps, speeding calcium removal and relaxation, making more calcium available for release on the next beat. So very, very important. Next, I want to talk to you guys about afterload. So here we're good. Yes, here we're good. Okay, now let's talk afterload. Afterload now is basically back pressure. Afterload is back pressure exerted by arterial blood. So let's look at that. So when we talk afterload, afterload is the pressure that the ventricles must overcome. It's a pressure that the ventricles must overcome in order to eject blood out of the heart. In order to eject blood out of the heart. You can think of it as it's the back pressure. It's the back pressure the arterial blood exerts on the aortic and pulmonary valves. About 80 millimeters of mercury in the aorta and about 10 millimeters of mercury in the pulmonary trunk. So pressure the ventricles must overcome to eject blood out of their chambers. Hypertension, it increases afterload, resulting in an increased end systolic volume and a reduced stroke volume. We talk hypertension. Hypertension is going to be a condition where we have increased blood pressure. Normal blood pressure we'll see is usually around 120 over 80 millimeters of mercury of pressure, but it can vary from 118 to 120, 122 as well sometimes. But again, that's just a range that we use there. However, your normal is going to be what your normal usually is. I'm saying 120. I'm not saying yours is 120, his is 120, hers is 120, mine is 120. And it's not going to be like that. My environmental factors, my physical, or my body characteristics, my genetics, they're all going to play a factor there as well. Sometimes some patients have a blood pressure that runs a little bit low. Their blood pressure could be 116 over 78, or something like that. So just a normal. Remember, we said these numbers that I give to you guys are going to be coming from these, 155-pound weighing 20-year-old male, 22-year-old male, and same thing then, with the female there as well. So just numbers we use for reference we have there. But again, you're going to look at the patient's history, and patient will know, or you'll look at patient's history and go from there. And also, if you don't have any of that, you're going to look at the patient's condition, their current condition. Okay, well, are they hypertensive? Are they hypotensive? Or are they in homeostasis? So here then, let's talk regulation then of heart rate. So I told you regulation of heart rate. Now in healthy individuals, stroke volume is relatively constant. Okay, in healthy individuals, stroke volume is relatively constant. Now if blood volume drops, or if the heart is weakened, stroke volume declines, and then cardiac output is going to be maintained by increasing heart rate and contractility. So in healthy individuals, stroke volume you'll see is relatively constant. Now if blood volume drops or the heart is weakened, stroke volume declines. And cardiac output then is going to be maintained by increasing heart rate and contractility. Stressors. You learned about stressors. Stressors can also influence heart rate and cardiac output. Now, factors, I want you to know, factors that increase heart rate are going to be called positive chronotropic factors, as we see here in the slide. Positive chronotropic factors. So factors that increase heart rate are called positive chronotropic factors. Atropine, dopamine, and epinephrine. All positive chronotropic factors. And those decreasing heart rate and basically are going to be known as then our negative chronotropic factors. So those decreasing heart rate are going to be our negative chronotropic factors. And our negative chronotropic factors will include number 1, acetylcholine, and number 2, digoxin. No, not did Jackson. Digoxin. 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 Oh, it spelled it right. Yeah, digoxin. Good. All right. Let's talk then autonomic nervous system regulation. Now, here in relation to heart rate, as I mentioned to you guys before, right? We said autonomic nervous system is gonna exert the most important extrinsic control. So again, our ANS exerts the most important extrinsic control affecting heart rate. Emotional or physical stressors, such as fright, rest, anxiety, or exercise, increase or decrease your heart rate. And they do that, we said, via your sympathetic and parasympathetic activation. So sympathetic nervous system activated by emotional or physical stressors. What happens is norepinephrine is going to cause pacemaker to start firing more rapidly. It increases contractility. Norepinephrine, you saw, binds to beta-1 adrenergic receptors, increasing heart rate. And then increasing contractility, faster relaxation, and then you can see here it offsets lower EDV due to decreased fill time. When we talk parasympathetic nervous system, it opposes the sympathetic effects, right? Acetylcholine now is going to hyperpolarize the pacemaker cells. It'll hyperpolarize those pacemaker cells by opening potassium channels, and this leads to a slower heart rate. Has little to no effect on contractility, parasympathetic nervous system. Little to no effect on contractility. Heart at rest exhibits what we refer to as vagal tone. And parasympathetic dominant influence is what that is. So again, we can see exactly what we saw before as well. When we talk chemical regulation of heart rate, I want you to know hormones, epinephrine and thyroxine are going to be involved here. So chemicals regulating heart rate, hormones, epinephrine and thyroxine. Epinephrine making its way from the adrenal medulla increases heart rate and contractility. Thyroxine increases heart rate, and it enhances effects of norepinephrine and epinephrine. Ions, so chemical regulation of heart rate, first by hormones, second by ions. We have to have a balance. You'll see intra and extracellular ion concentrations must be maintained for normal heart function. We have to have a proper balance of these various ions. Not sodium. You don't see we don't have sodium listed there. Not sodium. Why? Because it affects blood pressure by increasing water. Right? We saw that with endocrine. So here we see calcium and potassium. Other factors we'll see are going to include age, gender, whether we do exercise or not, the sedentary lifestyle or exercise. Body temperature will also influence heart rate. So age, gender, exercise, and body temperature all influence heart rate. Next, we've got our erythrocytes, our red blood cells. Now, when we talk about our erythrocytes or our red blood cells, here we could see they are going to look like these miniature donuts. Our red blood cells, our erythrocytes, are described as being biconcave. They're described as being biconcave. You can see that concave appearance on both sides. So biconcave, small cells. They're shaped like, or they look like, biconcave discs. And that concave region in the center is going to allow them to appear lighter in color. If you recall from anatomy, you were looking at red blood cells and they had that pale center. Okay, so they appear lighter in color at their thin centers than their thicker edges. These cells are bound by a plasma membrane. They're bound by a plasma membrane. However, they lack a nucleus. They lack a nucleus. We consider them basically little bags of hemoglobin. Because, right, what are they doing? They're not involved with, let's talk our white blood cells, immunity, right? They're not involved with any of that stuff here. What are they doing? They're just involved with moving all of this oxygen, all of these gases, carbon dioxide there as well. So little bags of hemoglobin. Little bags of hemoglobin. Hemoglobin, right? We've already talked about the other cousin of hemoglobin, right? In relation to muscle, okay? Carrying oxygen there. Next in here we've got, when we talk hemoglobin, let's go into talking more about then hemoglobin. Let's talk more about the function of these red blood cells. So where are we at here? Biconcave disc, they're anucleate, right? No nucleus. And essentially basically no organelles, just all millions and millions of hemoglobin. Okay, so filled with hemoglobin for gas transport. Oxygen and CO2 we're going to see. And you're going to have to know how all of that happens there as well. Now, there's certain plasma membrane proteins. They're going to contain certain plasma membrane proteins here as well. And one protein you have to know here is spectrin. Spectrin. This will be one of these proteins I want you to know here because spectrin is going to help to maintain the shape of these red blood cells. So we'll see if we don't maintain the shape of these red blood cells, they're going to be thought of as foreign invaders and by our body, by our blood cells, by our which blood cells? By our white blood cells. So when we go through and we talk, we'll see spectrin is going to be one of the important proteins inside of here in relation to basically our red blood cells. Another one we're going to get into is going to be hemoglobin. And when we talked muscle, we had there myoglobin. Here we have hemoglobin. So here now when we go through and we talk, let's see here. So when we talk hemoglobin, hemoglobin then we'll see now is going to be basically found. Let's come right over here. So go through here. You can check out the normal levels of basically erythrocytes in males and females. We would be doing a lab in class where we would actually go through and we'd give you a free medical exam and you'd check out these levels there. Now, due to basically the situation, we're not able to do that. So here now when we go through and we talk our hemoglobin is a red blood cell protein. So spectrin was one, and now here another one I want you to know about is going to be hemoglobin. Now, it's a red blood cell protein that's going to function in gas transport. It functions in gas transport, and it also helps to make our red blood cells red. It binds easily and reversibly. It will bind easily and reversibly with oxygen. Hemoglobin is made up of a red heme pigment. It's made up of a red heme pigment that's bound to the protein globulin. And you can see that here very well. Here you've got, specifically speaking, 4 heme groups, and each heme group is bound to a globin chain. You've got 2 beta globin chains on top, 2 alpha globin chains here on the bottom. So globin consists of 4 polypeptide chains, 2 alpha and 2 beta, which are found binding a ring-like heme group. Now, each heme group you can see here in greater detail, each heme group itself bears an atom of iron. It bears an atom of iron. A hemoglobin molecule can transport 4 molecules of oxygen because there are going to be, you can see, 4 iron atoms. So the iron atoms can combine reversibly with 1 molecule of oxygen. So I was saying then, one single red blood cell can contain up to 250 million hemoglobin molecules. They're little bags of hemoglobin. Little bags of hemoglobin. So each tiny cell can hold up to 100 billion molecules of oxygen. And there's various forms of hemoglobin. And we'll check those out in a second. But I want you to now look back here. Here we can see iron. So there's no iron, no oxygen binding. So the oxygen binding capacity decreases. So you probably heard of iron deficiency anemia. One type of anemia you'll have to know about. Well, there you go. What's happening there? These red blood cells now are going to decrease, or they're going to lose their ability to transport this oxygen. So there's not enough oxygen making its way to where it needs to go. So these patients are going to be usually feeling tired, sluggish, and so forth. So iron deficiency anemia, we supplement iron so that way then oxygen transport can increase there as well in these patients. So we're talking various forms of hemoglobin. Various forms of hemoglobin. More common ones are going to include, number 1, oxyhemoglobin. Oxyhemoglobin, it's basically the form of hemoglobin when you have oxygen bound to iron. So it's a form of hemoglobin when oxygen is bound to iron, and this hemoglobin is going to have a ruby red color to it. Has a ruby red color to it. Nice bright red color. And this is going to happen when you obviously load oxygen onto these cells, which is happening inside the lungs. And then deoxyhemoglobin, opposite there, it's when oxygen detaches from the iron. This is a reduced hemoglobin. A reduced hemoglobin. And it will take on a more darker color, a darker red. And our blood is not blue like you see in your veins. It's either ruby red or dark red. Well, then you can say, well, what is that? It's blue here. I see it. Why is it blue? No, it's the connective tissue. You probably learned in anatomy. The connective tissue, and then UV hitting it, it gives it that color there. And then third type I'd like you to know about here is going to be carboaminohemoglobin. Carboaminohemoglobin. So here we can see carboaminohemoglobin, carbon dioxide loading. And this happens in the tissues, right? And we're removing excess CO2 from the tissues and sending it off to the lungs. So you can see 20% of carbon dioxide in our blood binds to hemoglobin. That's carboaminohemoglobin.